Standard positioning steps for the skull or cranium include a 10 by 12 image receptor placed lengthwise in the upright bucky or in the table bucky with the patient prone, a 70-80 kV range, small focal spot, an SID of 48 inches, collimation on all four sides, and a marker placed on the right side. Remove all metal and plastic from the patient's head, including removable teeth. Place the patient in a seated or standing position. Place a lead shield on the patient's lap. For the PA skull or PA axial skull, center the mid-sagittal plane to the midline of the grid. Rest the patient's forehead and nose on the bucky. The OML is perpendicular to midline. The EAMs are equal distance from the surface. For the PA projection of the cranium, the frontal bone is of primary interest, and the central ray is directed perpendicular to exit the glabella. For the Caldwell method, direct the central ray to exit the nasion at an angle of 15 degrees caudad. Suspend respiration. For the PA skull, the petrous ridges should fill the orbit. For the Caldwell, with the 15-degree caudal angle, the petrous ridges should lie in the lower third of the orbit. Lateral skull, facial bones, sinus, and nasal bones. Place a 10 by 12 crosswise in an upright bucky or table bucky. 70 or 80 kVp, small focal spot with an SID of 48 inches. Collimate on all four sides and place the marker on the downside, whether it be right or left. Remove all metal and plastic from the patient's head, including removable teeth. Place a lead shield on the patient's pelvic region. The patient is positioned into an LAO or an RAO position with the interpupillary line perpendicular to the image receptor. Have the patient use his opposite arm to hold him steady. Adjust the neck flexion to align the IOML perpendicular to the front edge of the image receptor. The central ray enters 2 inches superior to EAM for the lateral skull. For facial bones, the central ray enters mid-zygoma. For sinuses, the central ray enters between outer canthus and EAM. For nasal bones, the central ray enters 1/2 inch inferior to the nasion and with a 2-inch collimation. Suspend respiration. For radiocanthal or Waters method, extend the patient's neck, resting the chin against the surface. The patient's nose will be about 3/4 of an inch away from the grid. Adjust the patient's head until the lips meatal line, LML, is perpendicular, or the MML is perpendicular, or the OLM forms a 55-degree angle with the image receptor. The central ray is perpendicular to exit the acanthion. Suspend respiration. The AP axial, Sella-Turcica, or Townes method. Position the image receptor so that the upper margin is at the level of the vertex, which will center the image receptor to the occlusal plane. With the patient's shoulders and head pressed against the bucky, flex the patient's neck to place the OML perpendicular to the IR, or the IOML perpendicular with an increase of 7 degrees in tube angulation. Angle the central ray 37 degrees if using the IOML and 30 for the OML, entering 1.5 inches above the superciliary arch. Suspend respiration. PA axial projection or Haas method. Rest the patient's forehead and nose on the grid. Adjust flexion of the neck so that the OML is perpendicular to the image receptor. The central ray is directed at a cephalad angle of 25 degrees to the OML, entering 1/2 inch below the external occipital protuberance or inion, or entering the level of the EAMs and exiting 1 1/4 inches superior to the nasion. Suspend respiration. PA mandible or PA axial projection mandible. Rest patient's forehead and nose on the grid. Tuck the chin. OML is perpendicular to the image receptor for the rami. Central ray to exit junction of the lips. PA axial is used for elongated view of the condyloid processes. Central ray, angle 20 to 25 cephalic, exiting the acanthion. True PA for the body, raise the chin to bring the acanthomeatal line perpendicular to the image receptor. Suspend respiration. Place the head in a lateral position with the side of interest against the image receptor. Have the patient close their mouth and bring their teeth together. Extend the neck to prevent cervical spine superimposition of the chin. Rotate the head in an oblique direction as follows. Rotate head, not just chin, 30 degrees to the image receptor for the body. Rotate the head 45 degrees to the image receptor for the mentum or symphysis. Rotate the head 10 to 15 degrees to the IR for a general survey. Mayo would like a 45 degree from the IR also. True laterals are for the ramus. Central ray is directed 25 degrees cephalic from the interpupillary line to exit the mandible or downside. Each axiolateral oblique projection demonstrates the region of the mandible that is parallel with the image receptor. Parietal orbital oblique projection, Reese method, aka 3-point landing. Place the patient's zygoma, chin, and nose against the grid. Adjust the head to the mid-sagittal plane forms a 53-degree angle with the image receptor, or the patient's head is 53 degrees from lateral. The acanthomeatal line is perpendicular to the image receptor. Center to the downside orbit, entering perpendicularly 1 inch superior and posterior to the upside top of the ear attachment or TEA. Suspend respiration.